Now. So Nick, welcome once again. Our IT has failed us. But I'm going to introduce you again, Nick Nation from Nutrition Nation, accredited dietitian who I use a lot for chatting with my patients. We were just attempting to start to talk about IBS, and one of the questions that I asked Nick was, IBS is a diagnosis of exclusion. And if you missed that bit, please go and look at the live onto Facebook. But we were just at the point where we were talking about, and I'd love it if you'd share your screen again, please. We were talking about the fact that you really do need to delve deep into a number of different disorders because they'll often present with IBS-like symptoms. But technically, it's not IBS if you have these things. Is that correct?
I can't actually, I mean, you can have celiac disease, for instance, and still have irritable bowel syndrome. So IBS is usually caused by something, and it could be really poor managed gluten-free diet for a long period of time that could then eventuate in not only having to go on a gluten-free diet with celiac disease, but also still have IBS. So technically, a few of these things, they can actually exacerbate IBS, and IBS can be born from these things as well.
I see. So like the name suggests, it's a syndrome, and a syndrome is a cluster of symptoms. Are there specific criteria that you need to satisfy to get a formal diagnosis of IBS, apart from excluding other diseases?
Yeah, so there's like with trying to determine whether someone's got depression, they have to fill out like a validated tool, like a validated survey. And so there has been something developed, it's called the Rome criteria as in Italy, Rome. And essentially you need to experience regular diarrhea or regular constipation or both, as well as some other IBS-like symptoms like stomach cramps or excessive bloating on a regular basis for at least 3 months. So you need essentially the mixed bowel movements with either bloating or stomach cramps, essentially for a quarter of a year to really get a proper diagnosis. And that's the best thing we've got at the moment, because you know the GP will send someone with suspected IBS to get a colonoscopy, for instance, and so the person goes and gets the colonoscopy, and then the results come back and they're perfectly fine. Like, the camera can't see this stuff. They can't see irritable bowel syndrome most of the time.
Yeah, right. And I look at all of these conditions here, and you know, I have so many endometriosis patients who their only symptom that they have is this IBS-like symptomatology. And you'll go in and you do a laparoscope and, oh, look, there's endometriosis, and you treat the endometriosis or even suppress it with something like the combined pill, and suddenly their IBS symptoms also settle as well. The other one I commonly see is pelvic floor dysfunction. One of the cardinal things that I see with that is disturbance in bowel habits, and then the bloating and the abdominal cramping as well, which, you know, I suppose pelvic and abdominal cramping can be difficult to discern in some patients. It's hard for them to be aware, well, is that abdominal pain or is that pelvic pain?
Yeah.
So
it's very confusing.
Say that again?
It's very, very confusing.
Yeah, because you wouldn't know whether to go and manage the gut and dietary side of things or manage the reproductive side of things with that. And they're quite different. They're quite
Or both, depending on how motivated the individual is. Like, obviously taking on a lot of different things all at once is always going to be tough for anybody. So just got to be real with ourselves and go, you know, what can I manage? Because treating IBS or treating gut health and treating IBS through diet is, it can be a really big change for some people.
So Nick, let's talk then to that. Let's move away from me as the gynecologist treating the endometriosis or treating the pelvic floor dysfunction. What are the things that women can do to manage their IBS, apart from come and see you, of course? What are the things they can do themselves and empower themselves, but also what are the things that you can offer them?
Okay, so like I've spoken to you in the past, there is a known gut-brain axis, a connection between the brain and the gut. So one of the first things I would recommend doing is trying to calm down, trying to stress less, and having a look at your lifestyle. And is it a calm and peaceful lifestyle, or is it something which, like, you're just not sleeping well, you're stressing, you're working hard, etc.? Because there can be something there. And that might be the only thing you need to do, right? Um, I had a patient, I'm going to confess, I had a patient the other day, and I was really close to recommending that she go on a low FODMAP diet. She satisfied all the requirements for the Rome 4 criteria for IBS, but she drank a hell of a lot of tea. And I was like, I was really close to recommending low FODMAP. And then I said, why don't you just cut the tea down to like 4 cups in a day for a couple of weeks and see whether that has any effect? And guess what? Hey presto, that's all she had to do. So she's just drinking tea 4 times a day instead of something like 12 times a day. And she had chronic diarrhea. And if she had kept drinking all that tea for another decade or two, maybe just cutting out the tea wouldn't have worked for her. Maybe she
So
would have.
what would that have been, like the caffeine in the tea that did that?
Yep.
Yeah.
Yep.
Wow.
And the caffeine is obviously speeding up the stool frequency and transit time. And then her microbiome would have suffered as a result over the long term. And then she may have had to have done something a little bit more invasive to try and combat her situation.
Wow, that's amazing.
Yeah.
So I like this gut brain thing, and I have chatted with a gastroenterologist who talks about sort of functional bowel syndrome. Is that different, or is that kind of in the same realms as IBS?
Totally the same realms.
So
Yeah.
same, just different name.
Yeah.
And part of his therapy was recommending to go and see a psychologist and implement some meditation and relaxation techniques, which
Fantastic.
the patient was actually like, "Are you kidding? You mean you're not going to give me a pill, a script, a colonoscopy, something? No, go and do some meditation for your gut." So that's really, really interesting. And I've read some papers on this. So there's actually scientific studies that have looked at this as well. So
Yeah.
it's not woo-woo, it's real science.
Yeah, and a lot of people will say just go on a low FODMAP diet, and then the patient or the individual will just go off and do that unsupported. And that's something you don't want to do, because you're in danger of really condensing your food availability. You know, you're really restricting when you go on a low FODMAP diet, and it's actually designed as a therapeutic diet. So you only go on it for a short period of time, because it's been found that if you do go on a low FODMAP diet for a long period of time, that your microbiome changes because you naturally reduce your fiber on this diet. And so in 10, 20 years time, if you continue to go on this low FODMAP diet, your gut might be even more unhealthy than it is when you first commence.
Mm.
And I guess what took me along this road of discussion is that it's only one option. There's other things, and more in line with what you were saying about the gastroenterologist. You can actually do gut-directed hypnotherapy.
No way.
Yeah, and it's been proven to be just as successful as going on a low FODMAP diet.
Wow. So can
Yeah.
I just shelve that FODMAP stuff for a sec? Because I do want to come back there. So coming back to the IBS stuff, um, aside from an individualized assessment of diet, which obviously needs to be done by an accredited dietitian, what are the sorts of, are there simple strategies that an individual, apart from the psychological stuff, can put in play? Or is it, no, you really need to have your diet assessed?
The way I normally like to work is, because not many people eat enough fiber in their day anyway, right? So what I like to do is I generally like to go, all right, I want you to, this is what I would normally say to a patient with IBS-like symptoms. I want you to, let's run an experiment, and I want to challenge your symptoms with increased fiber from a variety of fiber types. And so the patient goes off and tries that. And surprisingly, like almost 60% of the time, that works, right? So you're actually making your gut have to work harder by doing that. And one would think that it would just exacerbate your symptoms, but like about 60% of my cases, it's actually worked for them. And guess what? All of a sudden they're eating a diet which I recommend for the general population for great health and well-being. Then I would more look at like traditional gut irritants, like I'd hate to say it, but chocolate and coffee and alcohol and spicy foods, and then takeaway convenience foods, and trying to minimize or reduce the amount. But it really all depends on what they were eating in the first place. If they weren't eating any of that kind of stuff, then we don't even bother with that. Then my next protocol would be moving towards that whole low FODMAP protocol, which can take up to 3 months. And that's why I don't like to recommend it willy-nilly.
Yeah, okay. So let's just examine that FODMAP diet. I'm assuming there's more than just IBS that you'd use a FODMAP diet. It's, like you said, it's a therapeutic technique. Are there populations who are just FODMAP intolerant, like gluten intolerant or lactose intolerant? Are there populations that are just FODMAP intolerant, or is it a therapeutic thing?
Not to my knowledge. I think it is a therapeutic thing. Obviously, in Western society, where we've got a lot more stress, good old COVID, hey, working from home, where people are under a lot more stress, it seems to be more prominent. So we've got higher rates of colorectal cancer here in Australia than some Asian and African countries, and we eat a truckload more vegetables than they do. So we actually eat more fiber than some of these other countries are eating. And so you've got to say, well, why is that happening? Is it because of what we're eating, or is it broader than that? Is it the amount of stress that we place on ourselves? So yeah, I don't know. It's a tough one.
And so when you get to the point of saying, okay, we've done everything else, you're still symptomatic, we're going to move to a low FODMAP. As you said, that's a 3-month process, and it's addressing particular foods. Now, let me see if I've got this right. Fermented, oligo, di, monosaccharide, and polyphenols, FODMAP?
And polyols.
Polyols, okay.
Yes.
Okay. So can you give me some examples of the sorts of foods? Because I know there's a whole list. I've seen that fantastic Monash University app. I've got it on my phone. It's great. But can you just give us some examples of the high FODMAP foods?
So some of the main culprits would be things like garlic and onion. They seem to get people quite regularly. You can even go like, the list is, I suppose, it's quite broad, so it's really hard to avoid FODMAPs within the food groups. The ones where we don't necessarily see high FODMAP foods would be mainly fats, so your oils. But then as soon as you delve down into like foods like nuts and seeds and what else, avocados, things like that, then all of a sudden they've got FODMAPs littered all the way throughout them. There are options within like the nuts and seeds group. You can have 1/8 of an avocado. So the Monash diet is like, the research that they've done is down to such a micro level that they've determined that you can have 1/8 of an avocado, which I think's absolutely fascinating how they got to that point.
You'd have to like carve it and then quarter it.
Yeah. And
you just have that tiny little quarter.
And it's specifically a medium avocado too. So they're really descriptive, which is great. And in fact, they're pioneers. Like, the world looks to Monash University for IBS-like treatment. What else have we got? Lactose, so anything dairy, milk bean, usually a little bit more or a little higher than like cheese, because cheese's lactose content is less than the milk, and yogurt somewhere in between. Apples, stone fruits. What else have we got in there? That's a pretty good list, I think. There's some of the main players anyway. Obviously, there's more. And you can go on a more relaxed low FODMAP approach too, where all you do is cut out the main players. But then if you really want to do the full FODMAP protocol, then you get down into like all different types of foods, and some are restricted, some are completely non-negotiable, and some total green light, go for your life.
Yeah. And so I guess the point to make out of all of this is, because there is the potential, if you're trying to do it by yourself, untrained, unsupervised, and certainly for longer than 3 months, you have the potential to become deficient in other nutrients as well if you're constantly avoiding whole foods that are allegedly high FODMAP. So really, this should only be used therapeutically. This should only be used for a short period of time, and ideally under the care of someone who understands how to manage a FODMAP diet.
Yeah, because a part of the protocol, like anyone could go on a low FODMAP diet, go to Monash, print out a list of foods, and off you go, or get their app, which is fantastic. But you've actually got to re-challenge high FODMAP foods. And that's where the guidance and support really kicks in. So you need to systematically, whilst on a low FODMAP diet, systematically re-challenge a food that represents a certain subcategory of FODMAP. So for instance, with lactose, you might re-challenge milk, and you would re-challenge milk, say next week on Monday, you would do 125 mils of milk, then 250, then 375 come Wednesday. And so by re-challenging, you can actually work out your sensitivities down to a real micro level, which then obviously opens up the diversity of food choices. So you can actually go out to a restaurant, maybe not so much now, but you could get takeaway, and you could have a quick chat with the chef in advance and go, can you go a bit easy on that and replace it with that, and get by. So yeah, you really need to challenge it systematically. I get a lot of patients coming in saying, I think it's garlic, I think it's onion, but I'm not 100% sure. I was really stressed on that day. There's so many variables.
Mm.
And
And
so
garlic and onion go together, so how do you know?
right? And also a lot of people, when they cut out gluten, they get an immediate benefit. But is it the gluten in the food that's providing the immediate, like cutting that out is providing the immediate benefit? Or is it a FODMAP called fructan, which is providing the benefit? So they might be cutting out a FODMAP as well as gluten, but it's the actual FODMAP that they've cut out that makes them feel better.
Yes, of course, because all foods, whole foods particularly, they've got sugars, they've got, your carbs, you got your fiber, you got your protein, you got, like, you don't have them isolated, do you? Foods have combinations of everything, all those macros in them.
That's it.
That's a good point. So my last question before we wrap things up, Nick, is this: can you cure IBS?
Great question.
Or is it something you're going to manage for the rest of your life? Just like you manage asthma.
I'm an optimist. I firmly believe that if you were to treat your gut symptoms, over time, your gut would start to become more tolerant of some of the foods that exacerbate your symptoms. So I want to probably bring you back to that whole protocol of re-challenging. I would actually encourage my patients that go on this protocol to actually re-challenge the foods that they found they were sensitive to. And so the idea being that in 6 months' time, if you've got a healthier gut than you did, then perhaps we can actually move some of those problem foods from really sensitive to moderately sensitive to only just a little bit sensitive, and so on and so forth. And then over time, perhaps what we're going to have there is somebody that doesn't really have IBS anymore.
Yeah, fabulous. So there's a light at the end of the tunnel.
That's what I'm thinking, and I've seen it.
And with a bit of meditation and maybe a bit of gut hypnosis in there, You never know. He might actually come
Yeah,
out better than you were before.
exactly.
Beautiful. Well, Nick Nation, thank you so much for joining us again tonight, despite our IT troubles. If you want to know more about Nick, please go to nutritionnation.com.au. He takes consultations. If you yourself have an issue with IBS, I would highly recommend that you go and hang out with Nick. He's a wealth of information, and I love how you put it in such easy terms for everybody to understand. Stay safe, stay well. Wonderful to see you again, and we'll see you soon.